In this capture, we're going to take a look at cardiovascular assessment. Let's begin by talking a little bit about basic cardiac anatomy and physiology. So if you think back to anatomy, understanding that the heart has four chambers, we have two atria, two ventricles. The right side of the heart is going to focus most on unoxygenated blood. The left side of the heart is going to be your oxygenated blood. And it is the left ventricle that when it contracts, it pumps out the oxygenated blood to the rest of the body. The other piece that's important to kind of understand is your electrical system. So what actually controls the electrical activity? So impulses generate, or they should with normal functioning, from the SA node, conduct down to the AV node, through the bundle of His, down the bundle branches to the Purkinje fibers. The other thing you need to think about is this is all how things contract, but what is feeding the actual cardiac muscle itself? Because the cardiac muscle has to have enough oxygen and glucose to be able to make ATP to have the energy to even contract. So when we think about the coronary arteries, they get perfused during diastole, okay? And during diastole, that is the time that the ventricles are filling. So it's really important that you understand that, because when we start talking about problems related to the cardiovascular system, both this semester and then when you get into MedSurg 2 and MedSurg 3, if that diastole, if the heart is beating too quickly, that diastole time is shortened, that means there's less ventricular filling, which means there's going to be less blood pumped by the heart, but it also means reduced perfusion of the coronary arteries, and that's a problem. So you just want to understand that. Some basic terms and concepts you want to review for this. Cardiac output is the amount of blood that's pumped by the ventricle in liters per minute. So you want to understand that cardiac output is determined by stroke volume, which is the amount of blood that's ejected with each heartbeat, and how many times the heart beats per minute, your heart rate. Okay, so those two things are going to factor into the cardiac output. You will also see us, refer to a term ejection fraction. So this, we will hear it termed EF. And this can be evaluated based on an echocardiogram, but this is the percent of end diastolic volume that gets ejected with each heartbeat from the left ventricle. So normal is considered 55 to 65%. I mentioned stroke volume before. We'll talk a little bit more about that, but stroke volume is influenced by preload and afterload and contractility. So we're going to talk a little bit about preload and afterload. I do have an animation on here. I'm not going to show it as part of the capture. I'll have it up as a separate link, but it might be helpful for some of you that like animations and to help you understand those concepts. When we talk about preload and afterload, you think about preload is the volume that is in the ventricles at the end of diastole, okay? So for somebody that has fluid overload, or their cardiac valves don't close completely and you have backflow of blood, heart failure, they all have an elevated preload, okay? Now, afterload is the resistance that the ventricles must overcome to circulate the blood. So if you have somebody who has hypertension, okay, systemic hypertension, that left ventricle has to pump against a higher pressure in order to pump that blood out to the body, okay? So if you have increased afterload, that's going to increase the workload on the heart. If you have increased preload, that's also going to increase the workload on the heart because it has more stuff to pump, okay? So having a basic understanding of preload and afterload is pretty important. Other things you want to understand is the heart rate, which is a key factor in cardiac output, but the heart rate is controlled by the autonomic nervous system. So if you think back to A&P, the sympathetic and the parasympathetic nervous system, and it's controlled by baroreceptors, okay, because BP and heart rate are, connected. So if the blood pressure is up, these baroreceptors will try to stimulate the parasympathetic side in an attempt to lower the heart rate and the blood pressure. Okay, that's going to be important when we talk about hypertension. Pulse pressure is also an indication of cardiac output. So if you take the systolic blood pressure number and subtract the diastolic blood pressure number, that is your pulse pressure. And it should be between 30 and 40. If it's narrowed, that's a problem. If it's too wide, that's a problem. So looking at cardiovascular assessment, and we're going to start with health history because this is really important to kind of get an idea of what's going on with your patient. So certainly you want to know demographic info. And you're like, well, why do I want to do that? Why does it matter? We know that hypertension is more commonly seen in the African American population. So demographics do matter. Family and genetic history is important. History of cardiac disease within a family. There is a genetic component. You also want to know cultural and social factors. Okay, societies that really revolve around food and eating, and the way recipes are prepared, that might increase their risk for cardiovascular disease if they have a higher fat intake, higher cholesterol intake. You want to look at risk factors, some that are modifiable. Certainly obesity and somebody's weight, that is modifiable. Whether somebody smokes or not, that is modifiable. Non-modifiable, you can't change your biological sex. You cannot change your age. As much as you want to say you're not that age, the reality is your body knows. You want to know what medications they're on because some of them may increase cardiac risk. Okay, some medications we use to try to treat cardiac problems. So you want to know what meds they're on. Prescription, over the counter, herbals, vitamins, everything. You also want to consider their nutrition. What type of diet have they been on? As we talk about different cardiac disorders, there's some specific diet recommendations that we're going to make. Talking about elimination, some of the medications that we give, diuretics, to help treat blood pressure, certainly going to affect urinary elimination. We want to know about their activity and their exercise. We want to know about their rest and sleep. How is this affecting them? Are they getting adequate rest? Are they getting adequate sleep? We know that that's a risk factor for some of these if they're not. And that can be a huge cornerstone in helping to manage the problem. It won't fix the problem by itself, but it's definitely a component. You want to look at their self-perception, self-concept, their roles, their relationships. How are they coping? What's their stress tolerance? Because we know these things play a role specifically in blood pressure. We also want to know about their health promotion activities. Okay, are they getting regular blood pressure screenings? If they're above certain ages, are they being screened with their lab work for high cholesterol? Are they being screened for diabetes? Some common cardiovascular symptoms you want to kind of hone in on and be aware of. Obviously, chest pain, chest discomfort, and also any pain or discomfort in other areas of the upper body, the neck, the jaw, the arm, because cardiac related pain can sometimes radiate. You want to note if they're experiencing any shortness of air or dyspnea, both at rest and or with exertion. Okay, very important. We talked a little bit about that with respiratory, but cardiac and respiratory go hand in hand. Okay, so if they're experiencing those respiratory symptoms, we need to know. It could be a respiratory issue, but it could also be a cardiac issue in the sense that the heart is not pumping effectively to deliver the oxygen that is needed. You want to note the presence of peripheral edema, and if they have edema, how severe is it? What is that pitting level? Noting any weight gain or abdominal distension. Are they experiencing palpitations where they can actually feel their own heart beating? They might experience some unusual fatigue, some dizziness. They might experience syncope where they have a loss of consciousness just suddenly. Those are all things that you really want to kind of hone in on when we're looking at, cardiovascular symptoms. From a physical assessment standpoint, you want to get that general overview of the patient. What is their generalized color? What is their blood pressure? You may assess blood pressure in both arms, the right blood pressure, the left blood pressure. Are they experiencing orthostatic changes? What is their pulse pressure? Assessing arterial pulses, both central and peripheral. When we talk about arterial pulses, central, we usually think about carotid, femoral, and apical. Peripheral, we're thinking brachial, radial, popliteal, posterior tibial, dorsalis pedis. So are they there? What is their strength? Keep in mind the actual scale. In clinical, or when you're practicing assessment at home, when you're evaluating pulses, peripheral pulses, you should be grading them on that 0 to 4 scale. Remember, D refers to Doppler. So if you cannot palpate a particular peripheral pulse, before you mark it as 0, where it's non-palpable completely, you do want to assess that with a Doppler if you have one available. You're looking for jugular venous pulsations. So when you look at their neck, you're looking for JVD, distension, but also can you see the pulsations? When you think about heart inspection, palpation, and auscultation, so looking at inspection, can you see any pulsations in the chest? When you palpate over where the cardiac area is, where the heart is, can you feel that heart pumping? And certainly auscultating your heart sounds, listening at your 4 areas, ape to man, aortic, pulmonic, tricuspid, mitral, and you're listening for S1 and S2, you're listening for any additional sounds, you're listening to the rhythm. Remember, unless your patient is hooked up to a cardiac monitor, the best you can say about their rhythm is it regular or irregular. You cannot say that they have AFib just simply by listening to their heart sounds. Okay, you need to look at the electrical activity for that. You want to look at the extremities. What are the extremity colors? What's the extremity temperature? What's the capillary refill? And again, I threw the respiratory system on there, your focused respiratory assessment, because cardiac and respiratory go hand in hand. So lab tests, there are cardiac biomarkers. So these are enzymes that are released into the blood when ischemic injury occurs. So you might hear this as, a cardiac panel. We look at CK, which is an ischemic injury, but it's non-specific to cardiac. So CK might be elevated if your patient has a skeletal injury as well. For example, they had a bad fall, they sprained or really severely strained their ankle. But CKMB is cardiac specific. We can also look at myoglobin, but really what we often look for when we're considering was there cardiac ischemia or cardiac infarction, we're looking at the troponins, the troponin T and the troponin I. Now it's important to understand that they will sometimes order what we call serial troponins, where they'll repeat the troponins every 6 hours or every 8 hours. Because depending on how quickly the patient presents and when that first blood draw occurs and the timing in relation to the actual injury, that troponin may not be elevated yet, which is why they do serial troponins. Usually they do every 6 hours times 4 or every 8 hours times 3. But we want to watch them for 24 hours because if there truly has been an ischemic injury or an infarct, you're going to see a rise in those enzymes. And that would typically be indicative of a myocardial infarction or a heart attack. Now, your brain natriuretic peptide, or your BNP, this is something that we use to kind of evaluate fluid status, and if it's elevated, it's indicative of heart failure. We can do a CBC with differential and indices. In this case, we're mainly looking at, cardiovascular. We're looking at the RBCs, the H&H, the ability to carry the oxygen to circulate. We can look at BMP and electrolytes because electrolytes, particularly potassium and calcium, are critical in the electrical conduction system of the heart. So if you have low potassium or high potassium, that can affect electrical activity, which will then ultimately affect cardiac output. We look at the lipid profile. which has several components in it. It looks at total cholesterol, which our goal is to be less than 200. We look at LDL, which is the bad cholesterol. We like that to be below 130. For the HDL, that's the good cholesterol. That's the good stuff that we want. So for females, we like them to be above 55. For males, we like them to be above 45. And triglycerides, we also look at. And you can see for males, we like them to be below 160. Females, we like them to be below 135. C-reactive protein and homocysteine, these are different markers that they'll use to kind of quantify a person's cardiac risk for MI and cardiac events. ECG, or electrocardiography, this is essentially looking at evaluating the electrical activity of the heart. So this can be done in different ways. There's the traditional 12-lead EKG, and you will actually learn how to do EKGs, ECGs next semester in MedSurg 2. There's continuous ECG monitoring that are hardwire monitors or portable telemetry monitors. You may have been exposed to the portable telemetry monitor in clinical this semester. There's also ambulatory ECG monitoring. Typically, this is what we call Holter monitoring, where it is a portable monitor that the patient wears, generally over like a 48-hour period of time, that they then take back to the cardiologist, and the tracing gets read and everything. And basically, they're looking to see if there are any events that are occurring. They can also do telephonic monitoring now with the telehealth and the wireless mobile monitoring. That's pretty cool. We're kind of moving to that, to kind of evaluate how the patient's doing long term. We also have cardiac stress testing, and this can be done two different ways. It can be a physical exercise stress test, or it can be what we call a pharmacologic stress test. Either way, the heart is stressed to see how it responds to that stress, and to see how how it does with the rhythm, and how it does with vital signs, and do they become hypoxic or develop chest pain. Both of these require signed consent. They are MPO, usually 2 to 4 hours prior. They should be avoiding any type of tobacco, alcohol, or caffeine. Now, for the exercise stress test, the patient's going to walk on the treadmill, and the intensity, the speed, and the incline is going to progress according to whatever the facility's protocols are. And during this exercise stress test, they're going to be monitoring their continuous heart tracing. They'll be monitoring vital signs and also watching for symptoms. So basically, they're going to keep going until the patient is able to achieve a target heart rate without showing signs of ischemia, or they're going to stop if the patient starts developing chest pain, shortness of air, or dizziness. Okay. The pharmacologic stress test essentially works the same way, except instead of the patient physically walking on the treadmill and doing the physical exertion, we give specific medications to mimic the exertion that the exercise would have caused. Okay, but again, we're monitoring and we're looking for the same things. So some other diagnostic testing that relates to cardiovascular, chest x-ray. We normally think about this as a pulmonary thing, but we do get a decent picture, at least a one view or two view picture of the heart. And it can tell us about the heart size, and it can tell us about the position of the heart. So somebody with heart failure often has cardiac enlargement, so their heart would look enlarged on that chest x-ray. We can use fluoroscopy. This is helpful for placement of certain types of catheters and electrodes. For example, if they're placing a pacemaker or a defibrillator in your patient. They also have radionuclide imaging. So this is where they're giving essentially a radioactive substance, and they take pictures. So we can look at that to evaluate the myocardial perfusion through the coronary arteries. They can look at ventricular wall function. They also do things that have non-nuclear components, so CT, PET scan, MRA. an echocardiography, which is different than an electrocardiography. So it's very important that you understand the difference. So an echo is generally a non-invasive ultrasound. Usually a traditional echo is done just regular on the chest. Patient is in the bed. They use the ultrasound jelly and they use the probe just on the actual chest. And it can show the size, the shape, it can show motion of the cardiac structures, you can see blood flow, it'll measure ejection fraction. So it's very non-invasive. It can be a little uncomfortable for your patient just in the sense that they are pushing down on the chest wall with the probe, but it's relatively well tolerated. So that would be considered transthoracic. Now, a transesophageal echocardiogram, this is known as a TEE. This is where, generally done in a procedure room or an OR, this actually requires true informed consent because there's some risks here. The patient is NPO 6 hours prior. They have IV access. Again, this is typically in a procedure room or in the OR. But basically, they are sedated, and the TEE probe is passed down through the throat into the esophagus, and it does an ultrasound from in the esophagus and looks back at the cardiac function at the heart. So this patient is definitely sedated. We definitely need to numb the gag reflex, and because we're going in that oral cavity, we really have to closely monitor their oxygenation. But this gives a much better picture of the heart. Particularly, they look for, is there clots in the atria? Is there something else going on that might alter the plan of care, what they're going to be doing in the OR or the procedure that day? Finally, angiography. This is an invasive procedure, and you can do angiography at many different areas of the body. So there's coronary angiography, which is kind of where I'm going to be focusing right now. But there's cerebral angiography, where we can look at the blood flow and the vessels up in the brain, liver, renal. So with coronary, they're going to insert a catheter either into the femoral, the brachial, or a radial vessel, and they're going to thread it up into the right side or the left side of the heart, depending on what exactly they're going to be looking at. Once they thread it up there, they're going to inject some contrast media under fluoroscopy, and that will be able to show any narrowing or full-fledged occlusions of the coronary arteries. So very important during this, they very closely monitor the ECG rhythm, the vitals, any onset of chest pain. Depending on the purpose of the angiography, sometimes it's a diagnostic cardiac cath, sometimes it's a cardiac cath diagnostic with potential intervention. So if it's diagnostic, they're just looking to see is there narrowing or occlusions. If it's potentially interventional, they will look, they will find what the problem is, and depending on what the issue is, they might be able to intervene. They can do angioplasty. They might do stent placement in there to try to open up that coronary artery, open up that vessel, and reestablish blood flow. So before an angiography, especially if it's planned, they should be NPO for 8 hours. Obviously, they're going to have vitals. You want to do a focused respiratory cardiovascular and a neurovascular assessment. I mentioned on the previous slide that they're going to go in through a vessel. So whatever their approach is, okay, and sometimes it's more than one extremity. So your patient may actually have multiple sites. But let's say they went in through the right groin. I want to know what my neurovascular status was of that right lower extremity prior to the procedure, because I need to monitor that post. With angiography, because they are using contrast dye, you want to be aware if they have allergies to iodine or shellfish. Okay, very important. That dye is also harsh on the kidneys, so we want to look at renal function. Sometimes if they have an issue with allergies, they will pre-med them with methylprednisolone, which is a steroid, also Benadryl. In relation to the renal function, they will sometimes give Mucomyst to try to help protect that renal function. Certainly, if they are on metformin, we are going to hold that. If it's a planned angiography, they'll hold the morning dose, and we're going to hold at least 48 hours post-test. Okay, post-procedure, when the patient comes back, they're going to have frequent vital signs with neurovascular checks and site checks. So you're looking for, at the insertion site, you're looking for any type of bleeding. You're looking for the development of a hematoma, which would be bleeding underneath the skin. So you might see some swelling there, some ecchymosis that gets larger, okay? You're doing those frequent vital signs 5 to 15 minutes, and you're checking that site. This patient is going to be bed rest in a supine position with their extremity straight, whatever extremity or extremities were used in the procedure. How long they need to keep that position is going to depend on what type of vascular closure device they used. That's really going to be procedure dependent. They will be on continuous ECG monitoring. They're going to be on IV fluids. Again, we want to try to flush that contrast out of their system as much as possible, as quickly as possible. We're watching urine output. We're all about keeping the patient safe, but also keeping them comfortable, because depending on what type of vascular closure device they use, they might have to keep that extremity straight for 4 to 6 hours and stay in that position. So that's pretty uncomfortable there.